Hey everyone, and thank you for joining us tonight. I know Dr. Kutsch is real excited to get into his presentation, finish up the three-part series. Real quick before we get started, everyone is muted. If you have any questions, please use the box on the right side of your screen. That way we'll see it. At the end, we'll also have some time for questions. If we run out of time, we will get back to you via email in the next week or so. And if anyone wants to learn more or schedule a meeting or a webinar with us and your team, feel free to reach out to any of us or shoot us an email and we can get that all scheduled. So with that out of the way, Dr. Kim Kutsch is the CEO and founder of CariFree. He's been successfully practicing dentistry for 35 years and still practices here in Albany, Oregon, 3 days a week. He's the leading authority in ATP as it relates to Caries risk assessment. So I know we have a lot to cover today. I've seen all the slides, so I'll unleash you, Dr. Kutsch.
All right, hey, thank you, Cody. And welcome everybody tonight. We've got a great turnout tonight to kind of wrap up this series. You know, dental caries, is it a disease of choice? And we started by going through, you know, the biofilm model and then caries risk assessment, and then looking at all the individual risk factors, and then we started looking at treatment strategies. And so that's where we left off, and I kind of want to pick up there tonight. And so next up in treatment strategies is silver diamine fluoride. I used silver nitrate for years in my practice, but silver diamine fluoride got FDA marketing clearance this last year, and so I've been using that since that time. One of the things that we know about silver is that the silver ion is a very good antimicrobial activity. It inhibits the bacterial DNA replication, and it interferes with the cell membranes. Silver compounds have been shown to be an effective anti-caries agent. However, we don't completely understand exactly how it operates to actually accomplish that. We do know that the silver does kill some of the bacterial cells, and actually these cells then take on like a zombie-like behavior and actually continue to kill other bacterial cells even after they're dead. So we do know that silver compounds have been used a lot. I mean, stop and think about it for a second. You know, silver points were very effective as an endodontic therapy, for 100 years, and probably, some of that just had its nature due to the silver ion. Having an antimicrobial property down inside of the canal, because obviously they weren't necessarily didn't fit well inside of the canal. And silver amalgam restorations. Obviously the mercury has some antimicrobial properties, but the silver does probably as well. So looking at a case study then of silver diamine fluoride, which works extremely well, and I'll share a few studies of silver diamine fluoride with you here this evening. But the one thing that you have to be really aware of if you haven't used this product, Advantage Arrest is the name of the product. You can Google that and find the product. It just takes a drop of silver diamine fluoride. You dry the teeth. You paint the drop of that on. I like to use the Steve Duffin technique, who has done a lot of work with silver nitrate as well, and written a lot of papers on this. And then just follow that up immediately with a fluoride varnish, and it works extremely well. I'll share with you some of the data here, but the one thing you really have to be aware of is silver diamine fluoride is going to turn these decayed areas black, and I mean black, like you see in the slide here. So this isn't a material or a strategy to use for every patient. But if you've got a mouth of rampant decay like this and you just want to get your fingers in the dike and just arrest the decay and then have the ability to go back and restore these teeth individually, silver diamine fluoride is a great way to go about that. The patient just has to understand that these areas are going to be black. And so I use this on children as well, children that are like say 2 or 3 or 4 years old. As opposed to going to the OR, general anesthesia to restore a bunch of cavities. Silver diamine fluoride gives you another option, but again, it's something you want to discuss with the parents. Now, in addition to staining these areas and turning them black, it stains anything it comes in contact with. So you have to be really careful handling this stuff. If you get it on your countertop, it is going to be permanently stained. If you get it on your clothing, your lab jacket, it's going to be permanently stained as well. So just be advised, when you use this, to be very careful when you do that. Here's a study that was published in 2002. Silver diamine fluoride took place in China, and they followed 30 months. They took 375 3 to 5-year-olds, and it was actually very effective at arresting the dent and caries, and it was more effective than fluoride varnish. So in the study, they compared silver diamine fluoride to fluoride varnish to a control. The control, I think, was water, but it was superior to fluoride varnish, which we have routinely used in our practices on these high-risk caries patients anyway. In yet another study, this was published in 2009. This is a systematic review, and they looked at it and found that, again, silver diamine fluoride had the greatest prevention and arrest percentages and compared to fluoride varnish. So again, it's superior to fluoride varnish in terms of arresting or stopping that lesion from progressing. And again, here's another study. This was a single application of the silver diamine fluoride at 38% and followed up for 6 months, a year, and 2 years. And it was arrested the decay in these young children in this study as well. So you can apply this one time. I tend to apply it twice. If I've got a patient, and I use this on senior citizens, patients that are, we're just trying to, help their quality of life without having to create a lot of expense. And, people that have Alzheimer's or memory issues, impairment patients, I've had really good success using this. One drawback to silver diamine fluoride, aside from the fact that it turns the teeth black, it does not taste good. And so I get a lot of faces and a lot of resistance from patients over that. But again, here we are comparing it to glass ionomers and silver diamine fluoride. And again, it came out superior even to glass ionomers. And the arrestment rate went up to 91% when you used it twice a year. So you could either apply this like every 6 months, at least just twice a year, and then you should be good, particularly on these children. I like to treat them just twice and do that 1 month apart. So that works extremely well. But it's at least as good, if not better, than glass ionomer. And again, this was a paper that was published earlier this year, just a review on how to use it. And this is the product, the only product on the market that's available, Advantage Arrest from Elevate Oral Care. And it's safe and it's effective and it's easy to use. And it gives us just another weapon, another tool, in our toolbox when we're dealing with the high caries risk patient. I might use this on a patient where, again, I'm just trying to get everything stopped so I can go back and have the ability to restore these teeth maybe one at a time. And I have had, a lot of patients accept the fact that it's going to be black when it gives them the, that opportunity to go back and spread the treatment out over time. So silver diamine fluoride is something that I would recommend that you all investigate. It's something I really think you should all have in your offices. The next question I get, and I even had an email this week about probiotics, and I get this question pretty frequently because there's a lot of noise, on the internet about, the wonders of probiotics. And there are certain instances where probiotics are very effective, particularly if you're talking about intestinal issues. There's a great deal of science that supports that. When we come down to dental caries, the story is a little bit different. We've tried a lot of different bacteria, have been, advocated and tried and used in different delivery systems, from milk to yogurt to, they put it on lollipops, they put it on binkies for infants. So there have been a lot of different approaches to this, and the challenge is trying to get a probiotic to actually become a permanent member of the biofilm, which that has not been accomplished yet. At this point in time, if you're using any probiotic, you have to use it every day to get the benefit from it. The minute you stop using it, or the day you stop using it, literally within a few days, whatever benefit you had is gone. And that's true almost of all probiotics anywhere in the body. So it's something that's ongoing, and you have to use it a lot. Unfortunately, in dentistry, most of the studies that have been published find negative, very low or negative results. So it doesn't appear to have a profound impact on treating this disease. So I've got a couple of papers, more recent papers. This was from 2014, And this one looked at Lactobacillus rhamnosus, and this was actually an in vitro study. They used bovine enamel. They pH cycled the teeth over a period of 2 times to 6 times a day for 10 days. And what they found was not only did the Lactobacillus not inhibit the other cariogenic bacteria, but they actually joined the party and contributed to the caries process. So, and you got to think about this. I mean, we're talking about a Lactobacillus species here. They are strongly acid uric. So replacing one acid uric bacteria with another one, I don't really think is going to be a huge benefit in a disease like dental caries itself. And in this study that was published in 2013, they took children and they were using Bifidobacterium animalis, and they put this on the binkies and in lollipops and gave it to them as infants, and then looked at them as long as 4 years of age, and found that, number one, there was it did not become a permanent member of the biofilm, and there was absolutely no difference between the test group and the control group in terms of the caries incidence. And I would also say that a paper from about 2012 identified Bifidobacteria as a new cariogenic bacterial species. So again, we start to look at these studies, and it's like, does it make sense to try and change the biofilm by trying to load it with a probiotic, and it really just hasn't been very successful. Having said that, there was just a paper published, and I don't have it in the PowerPoint, but there was just a paper published that came out of the Scandinavian countries, and I think it was published in either JDR or the Caries Research Journal, and I think I think it was published in September, and it was looking at children, school-age children, and drinking milk that had probiotics, and it actually reduced the decay rate by about half. So, so every once in a while you'll find a study like that, but the majority of the studies indicate that, it's a good idea, but it hasn't really found its place in our armamentarium just yet. So I tell practitioners, if you want to try it, just don't make it your only strategy. If you want to recommend it to the patients, give it a try, see how it works in your hands, but don't make that the only thing that you're going to try. So that's basically, we've concluded the therapeutic strategies. We previously looked at fluoride, antimicrobial strategies, xylitol. Even had a separate webinar on xylitol this year. That seems to be a fairly controversial and hot topic from time to time. We talked about pH strategies, calcium phosphate in the form of nanohydroxyapatite particles, and then silver diamine fluoride, and then we just talked briefly about probiotics. The nanoparticles is interesting. I got a question. I was teaching a study club this weekend in Seattle, and one of the questions was, what do you tell the patient who is adamantly opposed to any nanoparticle? Like, that just raises a red flag, and it's like, well, the first thing they need to understand is that their saliva is super saturated with nanoparticles of HA and FA that their body actually produces. And so, we're actually just mimicking and copying, Mother Nature there. So I know that you may be adamantly opposed to any nanoparticles, but your saliva is super saturated with the nanoparticles your body actually makes. So, it's part of the natural world. Leaving the therapeutic strategies behind and now moving into the behavioral strategies, theoretically there's two things that we could modify. We have modifiable, strategies, and then we have non-modifiable. In the modifiable category, we've got home care and their diet. And I'd like to say theoretically that you can modify those. And non-modifiable would be like their medications or if they're special needs. And so you have to kind of work around those. So looking at that, this is always an interesting topic. Does toothbrushing actually prevent decay? And I would have to tell you, again, almost like probiotics, we don't have, while this seems to be intuitive and it seems to be logical, and we recommend every day to our patients that they brush their teeth at least twice a day, and but we don't have a tremendous amount of science to support that. Shockingly, very little science to support toothbrushing is actually reducing the caries rate. A lot of those studies go back to the mid-1970s. Horowitz did a number of studies of supervised toothbrushing with grade school children. However, we did have a paper published a couple of years ago in the Journal of Dental Research, and this was a longitudinal study looking at children that were taught how to brush their teeth in nursery school, in preschool in Scotland, and there were 99,000 participants, and they followed these people over a span of 12 years and looked at them and actually teaching them to brush their teeth in preschool versus, not teaching them at all, reduced their DMFT score from 3 down to 2. So that's a pretty significant impact, is teaching, young children how to brush their teeth. On top of that, there was just a paper published just this month in the Journal of Dental Research, and comparing people who self-report that they brush infrequently versus people who self-report that they brush frequently or routinely brush, and found that there was a statistically significant increase in the caries rate on patients that self-reported that they brush infrequently. So this was a systematic review. They looked at a number of papers. I think they boiled it down to about 3 papers at the end, but again, we have enough information to support the fact that we're toothbrushing. One thing that I would suggest to you is, if you stop and think about this, every time we do something, every time we eat, put anything in our mouth, the pH drops, and it softens the surface of the enamel. The teeth demineralize off of the surface. The nanoparticles of hydroxyapatite and fluorapatite are trapped in the biofilm and immediately held back to the tooth. And so then when the pH raises after that episode, that mineral is there readily available to go right back into the tooth, and so you've got a nice sense of equilibrium. Now, if you brush right after you eat a meal, so you go have breakfast and then you immediately brush your teeth, and say you even did something like had orange juice or grapefruit juice or coffee or something that's acidic, which again softens the enamel even more, and then brushed your teeth, particularly with any abrasive toothpastes on the market, you run the risk of increasing the certainly erosion and surface wear on your teeth using the toothbrush at that point in time. And so patients, I actually encourage my patients, seems kind of counterintuitive, but brush your teeth before you eat. Brush your teeth before you have breakfast, brush your teeth first thing in the morning, and brush your teeth last thing at night. And, don't do that immediately after dinner, do that right before you go to bed. So give your teeth and your mouth an opportunity to kind of recover, and don't brush those nanoparticles away. Or in addition, I obviously would recommend using a gel that had nanoparticles hydroxyapatite in it. But so we do have some good scientific support for toothbrushing now, so you can look at your patients with confidence. We know that helping establish a habit like toothbrushing requires a lot of motivation and a lot of encouragement and positive support. We're going to talk about behavioral change here in just a minute, but children, teaching them to do this, it takes a lot of encouragement and support, and daily encouragement for like 6 months, every day motivating your child to learn how to brush their teeth. When we go down to diet then, how does diet influence caries risk? Well, mostly we're talking about sugar. And there's a tremendous amount of sugar in the American diet, and we talked about that previously. We eat 23 teaspoons of sugar a day on average, and the World Health Organization, our target is like 2/3 of a teaspoon per day. So we're way off the chart there, and we eat 51 pounds of high fructose corn syrup every year on top of that. So we have some real health issues in the United States, and a lot of it deals with sugar. So we know that sugar appears to be a very addictive substance. It appears to be more addictive than cocaine even. And we know that we should have less than 5% of our total caloric intake come from sugar, and be like less than 3%. And so this was a systematic review. Again, this is published by the World Health Organization guidelines, but sugar certainly plays a major role in dental caries. In this study, we looked at children. They took 106 to 12-year-olds and looked at their diet and over a 7-day span of time, and then compared their diet to their DMFT scores, and found that basically the frequency of sugar was the most significant factor rather than the amount of sugar in their diet. But the more they snacked, and particularly snacked on sugar, the greater their DMFT scores were, and that that's not shocking. I mean, I think we'd all expect that. In the very next study, then, this came in the Journal of Dental Research last year, found that in adults, the linear dose response between sugars and caries, it was more about the amount was more important than the frequency. So, I often get that question, is it more important, how much sugar you're eating or how frequently you're eating? you know, obviously we're all very self-aware of the Stefan curve, but I would tell you it's both. You know, it's the amount and the frequency, because I can show you studies, continued studies that go both directions there. And then one of the things I want to bring this to your attention is something I wasn't even aware of, but certainly Gatorade, you know, we know that Gatorade, the #1 ingredient after water is sucrose, which is sugar. And, you know, so we have a lot of athletes drinking Gatorade. If you're going to do that right during an athletic event only, or maybe once a day while you're training, and you gulp it rather than sip it for hours at a time, you know, you can probably get away with that. But you take somebody that maybe is saliva compromised and even give them 1 Gatorade a day, and that may create a problem for them. But, you know, so a lot of the sports drinks people think are healthy, and they're doing a good thing for you. And so I've had actually patients who switched and just started drinking Gatorade was their drink of choice like all day long, because they thought they were really doing something healthy for themselves. So that's something to be really aware of, particularly with your athletic patients. And I've got patients who are a lot of marathon runners in my practice. And this is a product that's new on the market. It's called Goo. I'd never heard of this. And I had a veterinarian referred to me by a dentist that was suddenly developing. He had taken up marathon running 5 years ago, and now he's extremely healthy, but he's developing an average of 5 new cavities every year. And after 5 years of that, you know, this individual got referred to me, and so I sat down and went through his diet. And the first thing he said, I asked him, what do you eat? You know, how do you eat? What do you eat during the day? Tell me about that. And he said, well, I eat Goo. I had no idea what Goo was. I mean, you know, what are you talking about? He goes, well, I eat like 5 packets of Goo every day. I'm kind of carbohydrate loading because I run like 100 miles a week. And so, you know, I eat this Goo. And my dental assistant, who is sitting there, is actually a marathon runner herself. She goes, oh, I have some of that in the car. And I go, I've got to see this Goo. I need to see what it is. So she brought it in, and it's like, it's a tube of frosting, for crying out loud. Basically, it's frosting. It's sugar that's caffeinated. And I'm thinking, like, you know, and I look at the veterinarian, and I'm like, so would you eat like a tube of frosting like all day long? Would you think that would be healthy for you? And he goes, God, no, I would never do that. And I go, well, basically that's what you're doing. If you read the list of ingredients here, basically you're eating frosting. And yeah, it's great, you're carbohydrate loading, but you're doing this all day long, and it's how we eat the sugar that's as bad as the sugar itself. But, you know, here's somebody, an educated individual, thought that he was doing something healthy for himself, because this is like an energy gel, and it's good for you, and it's for runners. And, you know, so there are things out there that we all just need to be aware of. This paper I put in here, I thought it's kind of interesting. These 2 authors made an argument that dental caries is absolutely and 100% solely caused by sugar. Period. End of story. And, you know, there's a part of me that wants to say, yeah, you know, I could kind of buy that, but the problem is this is a multifactorial disease. There's so many other things going on, and like we discussed earlier, even the genetic predisposition. You can take away the dietary sugars, but the problem is even patients still that are immunocompromised or have saliva compromised, you know, eat no sugar in their diet, there still could end, you know, if they nibble all day long on protein, they could still end up with dental caries because of the Stefan curve. So it's kind of a simplistic way to look at dental caries, but certainly I would agree that sugars play a major role in dental caries. I mean, that's just, it's not the only cause, but it's certainly a major cause. And of course, you know, the American diet is ugly when we talk about sugar. And what do we know about sugar-sweetened beverages? I mean, I think this is a great graphic that we should all be aware of. Now, the problem is on the left side of this photograph, that bottle of water might have a pH of 4, and I know that we've discussed that previously. So it's like just because it's a bottle of water doesn't have any sugar in it doesn't mean that it might not damage your teeth. So we really want to encourage people to, you know, instead of continuing to add to the plastic bottles out of the Pacific Ocean, you know, buy a bottle, a reusable container, and drink tap water. You know, it's fluoridated in most communities, but the tap waters we know should be a pH of around somewhere around 7.15. So it's at least neutral. But you graphically look at how much sugar is in these different products, and I think, you know, we don't see that when we look at a can of soda. You don't see that it's actually a package of sugar like that. And I think it's important for us to kind of start to see it that way. one of the challenges we got, this paper came out, this made the New York Times, and this created a furor in the world of pediatric dentistry, because basically the study said that concluded that 100% fruit juice did not contribute to dental caries. And so I think parents heard a message of, oh, fruit juice isn't going to hurt my children's teeth, so it's safe to drink fruit juice. Well, again, it's the same issue. 100% fruit juice in this study did not contribute to dental caries. However, you have to read the paper. They talked about, in the study, it was a 4 to 6 ounce can of fruit juice, which will fit in the palm of your hand, and they drank it one time with a meal in a day. And so, yeah, I mean, I wouldn't expect that to create a problem, but that doesn't mean you can go, just give your kids, freely give them as much fruit juice as they want, like all day long. That wasn't the study. So we need to be really careful about that. And then certainly, soda intake in the United States is huge. I don't know how many billions of gallons of soda we drink in the United States, but it's an issue with sugar. And again, in this study, looking from 6 to 15-year-olds, the amount of sugar uses and the amount of medications both were related to their caries incidence. So when we talk about saliva, and I talk about patients that are saliva compromised, saliva is nature's, this is nature's biggest protective strategy for your mouth. Resting saliva has a pH of about 6.75. Stimulated saliva has a pH of 8.0. So when you start to eat and the saliva starts to flow, your body's immediately trying to raise the pH in your mouth and try and help you protect your teeth. So if you don't have enough saliva, you absolutely are, tip the equation in favor of the dental caries or the cariogenic bacteria, because, we have more prolonged acidic episodes in the mouth which select for those bacteria. And that behavior, that acidic acid uric behavior of those bacteria, which ends up dissolving the mineral in the teeth. Looking at the number of medications that we take in the United States is amazing. 70% of Americans take at least one prescription medication a day, and that's across all age demographics. From newborns to 90-year-olds. So that's a big issue, and 50% of Americans take 2 or more, and these start to compound, and I know you guys deal with this. I do in my practice as well. The patients that have medication-induced xerostomia, this is huge. In fact, when we go back to those usual suspects that we talked about at the beginning of this series, the number one suspect, 63% of my patients self-reported a dry mouth. So that's an issue for us ongoing. So again, you have patients like this, they have got, this patient was high risk for dental caries, averaging 2 new cavities per year, and her home care is impeccable. She just didn't have any saliva, and it was medication related. So then we've also got Sjogren's syndrome, and I've got a number of Sjogren's syndrome patients in my practice as well. So those are quite a high challenge too. So that could contribute to dry mouth, and then we certainly got meth mouth. Depending upon what community you're in, it could be a bigger problem than other communities, but certainly it seems to be a major problem pretty much everywhere. So methamphetamines dry the mouth out, and then these people also probably have very poor diets, and that's just a recipe for disaster. So anyway, so that's always one to be aware of as well. When we come to special needs, actually, just before I leave that topic of medications, I can't take the patient off of their medications. I'd like to get them off the meth, if that's a possibility, but I can't take them otherwise off any of their medications, and so we need to be able to help them understand how that relates to their dry mouth, then how much more susceptible they are in that Stefan curve to any kind of snacking, their diet, particularly sugar intake, trying to keep their mouth wet, trying to stay hydrated. So that's an issue to discuss with them. And then special needs, again, I can't change that. And so, and those issues for a special needs individual may be a dietary or a home care issue that they're not capable of doing anything about. And it might be medication related as well. So you've got, several things going on there for the special needs patient, which particularly makes them a challenge for us as well. when we look then at, the modifiable strategies, how do we help patients make these changes? And, we're taught how to drill and fill teeth, and we're taught how to diagnose where their cavities are, how many cavities they are, and how we're going to restore them. And we're taught really well how to do that, and we're all extremely well trained. But the problem comes down to, so I was never trained how to help a patient make a behavior change. And if it came down to my patient's biggest issue was their diet, or their biggest issue driving their biggest risk factor was their home care, I was taught how to teach them how to brush and floss and to tell them that they needed to brush and floss. And I mean, I and my hygienist have been doing that for 37 years, and it's like beating your head against the wall. Telling somebody they need to do something and showing them how to do it doesn't mean they will do it. I mean, that is not going to impact their behavioral change. So I went through a 2-year coaching program, a wellness coaching program, to try and learn those skills so that I could be more effective in terms of helping my patients make behavioral changes. So wellness coaching is really kind of an extension of the motivational interview, where the motivational interview is really trying to assess where somebody's at in terms of thinking about making a behavioral change. Wellness coaching is kind of kind of takes them beyond that and says, okay, what do you want to do? What is your goal? How are you going to accomplish it? What's your first step going to be? And how are you going to remember to take that first step? And what support do you want from me? So it's really a matter of all the work is on the patient. I'm not telling you what to do. It's all you telling me what you're going to do, how you're going to do it, and by me asking you open-ended questions and encouraging you, getting you to actually design the behavioral change for yourself, and knowing yourself as well as you do, what kind of things work for you, what will help you be successful at doing that. So wellness coaching is really about helping the patient identify, how can they make this behavioral change that they want to make. Ferocious Knight was my instructor, my wellness coach, taught me this at the Barak Institute in Portland, Oregon. There's 2 programs in the country on wellness coaching. One's in Portland, one's in Florida. Ferocious is world-renowned as a coach, and I spent 2 years learning how to, just change the language. And it's not really, I mean, it's no big secret. It's really just a matter of us changing the words we use with our patients, and just kind of changing our approach. I think we're all aware of that, I was asked this question in my programs, how long does it take to establish a new habit? And, there's this 21-day thing. Everybody knows it takes 21 days to establish a new habit. And this is the biggest piece of crap science that ever came down the pike. All of this goes back to a book written by a plastic surgeon in New York in the 1960s, and where he said that, gee, when I give somebody a new nose, it seems to take about 21 days before they get used to it. And so that was the new habit. You got a new nose, your nose job, and it took you about 21 days to kind of get used to it. That is not how human behavior works. And so when we talk about developing a new habit, and not developing a new habit, which you could maybe do in 21 days, but a sustainable habit, because you can lose that new habit in 1 day. So we really talk about sustainable new habits. This is a long-term project. And I mean, I was just reviewing some cases today that I'm going to use on some lectures I'm going to do in Japan next month. And I've got patients, I've got 9 years of behavioral change going now, and I photographed and looking at them making incremental change, 2 steps forward, 1 step back, but slowly making progress. But it's a matter of years in some patients. Some patients will do this in 30 days. Some people it takes 5, 6, 7, 8, 9 years. So one thing you have to understand is they're going to change at their pace, and we have to be patient, and we have to help them, identify how can we best support them to help make that change. The best study that I could, that I could share with you is published in 2010, and depending upon the challenge of, or the difficulty of the new behavior, or how challenging it is, can take a new behavior that's sustainable, can take somewhere between 66 and 254 days, can take almost, 2/3 of a year, 3/4 of a year, 9 months to get a new habit that's actually sustainable. And then the other thing we know about that is it takes pretty much daily support or reminding and encouragement daily for 6 months. So I don't know about you, but I know that I've tried to lose weight. I've tried to make some behavioral changes in my own life, and I find that it's not easy, and it's something I need to constantly remind myself, if I'm going to be successful at that, it takes a lot of time and it takes a lot of effort. Things that we know from human behavioral studies are that our attitude affects the outcome. We know that in scientific studies, just the study itself and our expectation influences the outcome in a scientific study. Our attitude for our patients affects the outcome and their ability to be successful as well. So it's really important that we have a very strong, supportive, encouraging, positive attitude with the patients, and outwardly let them know, I know you can do this. I see you being successful. I absolutely believe that you're capable of doing this. I know you're going to be successful. Continue to give them that positive support, because if you're sitting there and you're not saying, giving them positive encouragement, in fact, and your inside voice is going, yeah, this is never going to work, that gets communicated non-verbally to the patient, and it's really, we play a major role in our attitude on how successful they are. I think, at some point in time in your life, somebody's probably encouraged you to do something that you really didn't think you were going to be very good at, and then you only did it because somebody really, you kind of got, they convinced you that you could do it because, they gave you all that positive reinforcement, and then you went out and tried and found out that maybe you were actually capable after all. And I know that I've had that experience in my own life, things that we were afraid to try or afraid to do, and had somebody say, oh, man, you're going to be so awesome at that. And then went out and tried it and found out, you know what, I have some talent in this arena that I didn't see in myself. So being able to see that in other people and communicate that to them is very important. We also need to be non-judgmental. When we sit down, there's a lot of emotional baggage and shame and guilt associated with dental caries. When your teeth look bad, people won't smile. They hold their hand over their mouth. And there's a tremendous amount of baggage on that. And so one of the most important things for us, too, is to not be judgmental, but to sit down and say, tell me more about that. Here's what we found. Here, let me help you. Here's how we can help you. What are your goals? What do you want to do? Again, just not judging them as being a bad person because they have big cavities in their teeth, but being able to look at this as a person who has a disease that I have the ability to help. And it's a life-changing, being able to help somebody like that is a life-changing process. So being non-judgmental is very important. And then one of the challenges that we all have, too, is called proactive interference, that the thing keeping me from developing that new habit is my old habits. And so they kind of get in the way. Yeah, I really want to stop doing that, but I kind of got a habit of doing this. And so it's kind of, you have to unlearn some of your old habits to actually develop the new habit at the same time. So that's something to always kind of be aware of. It's always good for ourselves if you're trying to make those changes as well. And then this was a paper that I use a lot, and I think it's really important for us to understand. Changing a dietary behavior around sugar is harder than changing somebody's behavior around alcohol. Sugar is more addictive than alcohol. So getting somebody, this is something that we need to be really aware of. This is a challenge, a real challenge for us. And so, alcohol is certainly a 12-step program. Maybe changing a diet is maybe is a 13 or 14-step program, but it takes time. So I think we just need to be aware of the fact that making changes, helping somebody make changes in their diet is not an easy proposition. So in our coaching process, the one thing that we need to do is ask open-ended questions. Those are questions that can't be answered yes or no. And we're always really good at asking things like, do you floss? How many times a day do you floss? And we're asking them these real closed-ended questions. And we really need to start asking them questions like, what would you like to focus on? What are your goals? Tell me what you would like me to help you accomplish. Tell me what your smile looks like, your ideal smile. Tell me what you want to do. And a lot of times you can get people kind of grounded to feeling for why do they really want to make this change by, tell me how this has affected you, how has this affected your life. And being non-judgmental, this is a really great phrase to use. I use this one all the time. You need to work this one into your habits. Tell me more about that. So when I ask a question like, tell me about what you drink during the day, or tell me, like this veterinarian, tell me what you eat during the day. Well, I eat 5 packages of goo. I'm like, that's interesting. Tell me about that. Tell me more about what goo is. Tell me about it. And it's not just, so it's not saying like, you do what? You eat 5 packages of goo? I did then confront him after I understood what the goo was and ask him if he would eat frosting. I just want to make sure he was aware of what he was actually eating. But so that's a really good phrase. Tell me more about that, because you're asking the patient to tell you about what they do, tell you about their behaviors or their diet or toothbrushing or floss or whatever. It's non-judgmental. It's just like, tell me more about that. And most patients, most people, when asked to tell you more about something, will tell you more about it. One of the things, traps that we get into too, is that we tend to tell people what they need. You need 3 crowns and a root canal, and you need this, and you need to have your teeth cleaned twice a year, and you need to do this, and you need to brush twice a day, and you need to floss, and and when we get down to this, are we telling them what they should do, what we believe they need to do, or are we asking them what they want? How can I help you today? What are you here for? What do you want? Because that goes from, if you've ever, and I'm sure you all have, spent time with a car salesperson, in particular a high-pressure sales event, so are we trying to sell them something? Are we trying to sell them a disease, a bleeding pocket they don't even know they have? Are we trying to convince them they have a dry mouth? Are we trying to sell them something they don't know they need, or maybe they don't want? Or are they asking us to help them with a problem they perceive that they have? Are they actually buying something from us? So I really want to go from selling dentistry to be in a position where I have patients that are coming to me to purchase dentistry. And so that's a complete behavioral change in the dynamics and in our conversation. But it's just by changing the words, we walk away from this trying to sell you, you need to do this, and start talking about, what do you want? At the end of the day, what are your goals, and how do you see yourself accomplishing that? Where would you start? How would you solve this problem? What would your first step be? How are you going to remember to start that first step? How can I help you? How can I help support you make that change? So in the wellness coaching, we report to the patient, not that you have this, you have that, but here's what I found. When we did your exam, here's what I found. We found 6 teeth that had decay in them. One of the things that we identified is that one of your major risk factors is the amount of sugar that you eat in your diet. We talk about these things without, like, it's the third person thing. It's not you. So that we're not trying to place guilt and shame on the patient. I want to talk about, here's what I found in a third person's, talking to that third person. So this is what we found, and you and I can sit and talk about that objectively without you feeling that I'm judging you. And then it's like, where do you want to start? What do you want to work on first? If I've got 3, one of the things that we know about behavioral change in humans is we're only capable of making 1 behavioral change at a time. If you have a dietary issue and maybe 2 or 3 dietary issues, and you've got a home care issue and you don't floss, and you've got other issues as well, I'm not going to tell you that you need to start doing these 18 things every day when you're currently not doing any of them. We're going to be lucky if you pick one and 6 months later, we've helped you establish a new sustainable habit. I mean, that's the reality of what we're up against here. So I used to be real invested in telling the patient, here's a treatment plan, here's phase 1, phase 2, phase 3, and it all made sense to me. And we're going to do it this way, we're going to do it my way, and now you need to work on this first, right? And I don't do that anymore. It's like, the patient's going to be more successful if they get to choose. So here's, like a couple of items that, if you want to accomplish this, the behavioral changes for you to work on. Which one do you want to start with first? Where do you want to start? They need to brush and floss. They need to change their diet. They need to do this to be successful, yes, but I'm going to let them pick where they start. They're going to be more successful picking something that they're more invested in. And so, again, when it comes down to restoring the teeth, there are certain things I have to do first. Like I have to do the root canal before I put the crown on. I mean, that's just logical. I have to extract that tooth and let the bone heal and do the bone graft before I can place the implant. I mean, there's some things that I can't change the sequence on, but if it's just a matter of which tooth do you fill first, if the patient wants to decide that they want this done first rather than that, I mean, I go with the patient. I'm not invested in that anymore. I let them, put them in charge. You know, I work for them. And then what support would you work for me? Would you like from me? But please understand, I'm not coming home with you, right? I'm not going to stand in your bathroom and tell you to floss every day. So it's like, if you would like me to check in with you on a monthly basis, you know, a phone call, a text, or an email, I'm happy to do that. But on that daily reminder, that's something that you need to develop for yourself. So you tell me what your plan is. You need to figure out how to do that. You tell me how you're going to be successful. You come up with a plan. Where you're going to start, how are you going to remind yourself to do that? So, you know, in closing here this evening, and this is going very well, you know, looking at those usual suspects that we've talked about continuously through this series, 63% of the patients in this study self-reported a dry mouth and have a salivary issue and or are taking medications that contribute to dry mouth. 55% of the patients self-reported that they're either eating too much sugar or they're eating too frequently. 46% of the patients indicated that they recognized plaque buildup on their teeth, and 51% of them actually had a high Caries screen score. And then we've got the wild card, you know, genetics, which we really can't measure at this point in time effectively. And so, but it's really something that if you come up blank on all the rest of these risk factors, these usual suspects, you may be dealing with a genetic issue that these people are predisposed to having dental caries. So it's just one to always keep in the back of your mind. But at the end of the day, it's all about Kaiser Sose. You know, it's all about the pH in the mouth, those prolonged periods of low pH that lead to demineralization and permanent mineral loss from the teeth and cavitation. So when we look at our treatment strategies, we want to target them to the risk factors. So, you know, the suspects, the risk factors, drive the treatment strategies. If we've got a bacterial issue, I'm going to recommend to the patient an antimicrobial strategy and or talk about, you know, home care behaviors and try and coach them on that. If they have a dietary issue, we're going to talk about sugar and sweets versus snacking. You know, how you eat or how you drink something. You know, are you sipping that cup of coffee for 4 hours in the morning, or are you drinking it just right away with breakfast and, you know, getting it out of the way and then not snacking, and, you know, for the rest of the morning? If you have a dry mouth, we want to really help them be aware of just keeping their mouth hydrated, drinking water, drinking neutral water or even alkaline water, and just neutralize to support the pH in the mouth. And if you're going to snack or you're going to eat, we really need to, you know, go to an outside source, something like an alkaline gel or a spray or a rinse or even just tap water. And if you suspect they have a genetic issue that's contributing to their risk, then it's really just a matter, again, about helping them support wellness, helping them understand the Stefan curve, and trying to minimize their acid exposure, acid episodes during the day, and so that they can, you know, spend more time remineralizing their teeth than they are demineralizing them. So those treatment strategies then are directed at the risk factors, which come from our risk assessment form. You know, we target and go directly to that form. I want to leave you tonight with my protocols for these caries risk categories. For my low caries risk patient, my protocol is this is an always. Every patient in my practice gets a risk assessment form and the caries screen once a year. So that kind of gives me a baseline to talk to the patient every year about. I offer them, you know, these patients are healthy. You know, they don't have any risk factors. They don't have any disease indicated. They don't have any damage to their teeth. So I offer them a 12-month fluoride varnish. Offer them, CariFree products, pH neutralizing strategy that has xylitol, and HA and fluoride in it. Talk about that, and then I educate them about risk factors. You know, if you come in 6 months for your checkup or 12 months and you've started taking a medication or you've had some major change to your diet, I need to know that. That's something you need to share with me. So, you know, please let me know that, because you could be healthy today and you start taking 2 medications and it dries your mouth out, and depending upon how your diet impacts that, you may be back here in 12 months and have 6 cavities in your teeth. So I need to be able to help you, you know, kind of prevent that. For the moderate caries risk patient, Again, so this isn't always Caries risk assessment once a year with the biometric with the Caries screen. I'm going to recommend for them now these are people who just have risk factors. They don't have any disease indicators yet. I'm going to recommend twice a year fluoride varnish. I'm going to recommend again, a multiple strategy like the CariFree gel, the CTX4 gel. And then I'm going to talk to them. I'm going to do behavioral coaching targeted at the risk factors. And again, like we talked about, helping them identify what those risk factors are, but then actually putting the work on their shoulder to figure out where do you want to start, which one do you want to tackle first, how would you go about it, how would you solve it, where would you start, how are you going to remember to take the first step, how can I support you? So those are the kind of questions that, we just work those into our language. We talk to the patients just like we always have. We just use different words. And for the high caries risk patient, again, caries risk assessment with the Caries screen once a year, they're going to get a 3-month fluoride varnish always. That's an always then. 3 months, every 3 months they're going to fluoride varnish. They're always going to be put on a multiple strategy. If we can get them to just substitute with their toothpaste for a 5,000-part gel, I may or may not use an antimicrobial strategy. So think about this, some of the patients you've seen here tonight, for the ones that have a lot of plaque all over their teeth and they've got a high Caries screen score, that's somebody I'm going to put on an antimicrobial strategy. But you could have the patient that has a dry mouth and has perfect home care, has a low Caries screen score, doesn't have any plaque on their teeth, but is developing 2 or 3 cavities a year, but they don't have a bacterial issue. They have a saliva issue or they have a dietary issue. So that patient I am not going to put on an antimicrobial agent. So I use the Caries screen, meter and swab, to determine for these patients whether or not I'm going to put them on an antimicrobial agent or not. So that's when I use the CTX4 treatment rinse. If they've got a high Caries screen score or a lot of plaque buildup, yep, they're going on it. But if they have a low Caries screen score, I'm not putting them on an antimicrobial rinse. It doesn't make any sense to me. I may or may not use silver diamine fluoride, recommended for that patient, depending upon how many lesions they have, what their goal is, how they want to go about accomplishing this. And then again, I'm going to use the behavioral coaching for their risk factors and just trying to help them, make those changes in their life. At the end of the day, this all comes down to balance, and a healthy balance in your mouth is you don't have those prolonged periods of low pH in the mouth, which are causing the demineralization of the teeth. So it's really about having an effective diet. It's about having enough healthy saliva, and it's about good home care habits as well. So, and that creates balance in your mouth, and it creates balance in your life and in your health as well. You can't have a mouth that's full of tooth decay and think that you got a healthy body. So it all comes back to the concept of balance. So we've got time, Cody. We actually finished in time to get a couple of questions in tonight. This has gone extremely well. If you would like to schedule a live demo for your team to learn more about CariFree, you can call this number or go to this site. And Cody, you should be there, and we can field a couple of questions.
Yep, and we have a few. So the first one is actually 2 questions, and they kind of relate to each other. So I'll ask them both. What is your baseline recommendation, both short-term and long-term, for a patient that is completely saliva compromised? And then the second part is there a different approach between the different causes? So if they had, i.e. medications, Sjogren's, radiation.
Oh, that's a great question, Cody. So let me go back. You asked about the baseline recommendation, if I got the question right, short-term and long-term for the patient. Now you said completely saliva compromised, so this is a person who really has just not hyposalivation or medication-induced xerostomia, but really has xerostomia, really doesn't have much saliva at all. Is that the question we're
they may be asking that, but they could also mean just I don't know, or a saliva disadvantage as well.
Okay. So let's take 2 quick case scenarios. One is a patient that has hyposalivation, which means they have reduced salivary flow. That's a term that I've borrowed from John Featherstone. I like that term. Or they're saliva compromised. So and typically that either comes about from age. Most of your senior patients are going to have less saliva. Our salivary glands, like the rest of the body, don't do work like they did when we were younger. And or it's probably more likely related to medications. And certainly when you look at the medication use, in the United States and literally in all ages, I used to just think of senior citizens, but now it's really children as well. So for the patient that's just salivary compromised, I really, again, just want to talk about keeping the mouth hydrated if they're going to snack during making sure that they're really aware of how that changes the damage, to the teeth, how that compromises the balance in their mouth and the recovery from every time they eat. So if they're going to do something that has sugar in it, or they're going to snack frequently during the day, they need to understand how that's going to impact their mouth. And so really talk to them about thinking about altering their dietary habits so that they have the least amount of impact on their teeth in terms of decay. And then again, being able to neutralize your mouth, use products that are going to help neutralize and replace the saliva, the pH benefit, the buffering capacity, or the buffering benefit of the saliva, using products like the Boost Spray or the CTX3 rinse. Certainly I would have that patient on a CTX4 gel, probably the gel 5000, probably for life at that point in time. And then again, just tap water. I mean, if nothing else, you're going to eat a snack, guys, just rinse your mouth out with tap water. That's a huge improvement. And make sure that you drink enough water during the day. I think a lot of us are running around in this country, that are in a state of dehydration because we just don't drink enough water, period. Now, on the other hand, for the patient that is completely salivary compromised, like I'm talking, they either had head and neck radiation, lost a lot of their saliva, or they have Sjogren's syndrome, or they're taking so many medications that they literally, their cheeks are stuck to their teeth, then that's a whole different kettle of fish. And on those patients, again, I would, depending upon what their bacterial levels are like, I might put them on an antimicrobial strategy, kind of short term, let's say 3 months maybe. If their bacterial levels still stay pretty high, I might put them on for up to 2 years. I encourage them to use that. This is a patient that I might use, so be more inclined to use silver diamine fluoride on, particularly on root surface lesions, just to rest them, while we talk about other changes, and help the patient, work through those changes. I have put a number of Sjogren's patients and head and neck radiation patients into trays, and trays with the CTX4 gel 5000. And just have them put the gel in and wear the tray at night, or at least wear it for half an hour during the day. So I would put them in a tray potentially. I've stabilized a number of patients and kept them decay-free for years, with the daily use of a tray. So that's an option as well. Obviously, you're going to pull out on that patient. You need to pull out all the guns. The fluoride varnish 4 times a year. You just need to, use the shotgun effect on them. Use everything that we've got to, help manage that. But a tray is, I found to be really effective with the CTX. Now, would you do that differently, whether it was a medication, Sjogren, or radiation? The answer there is pretty much no, because with the exception of the radiation patient, the Sjogren's patient is probably not going to get better. They're not going to get more saliva at any point in time. The medication patient not going to get more saliva either, unless they go off their medications, or they change their medication that doesn't impact them that way. For the radiation patient, in the short term, they lose a lot of saliva, but long term, their salivary glands tend to recover somewhat. So they go from that xerostomia into more of a hyposalivation situation that you might be able to manage without a tray. I've got one patient I'm thinking of right at the moment that we had him in trays for a couple of years, and then we're able successfully just to manage him without trays by just having these other products. Now, pilocarpine is always something that you can try. You can subscribe it in tablet form. They can take the pilocarpine. It has a short-acting benefit, but one of the issues with that, it will produce more saliva, but it will also produce more tears and more sweat. And so, it secretes, every gland in the body secretes more. So that's kind of a drawback for that. And I've tried that with a couple of patients, and they used it for a couple of weeks and then refuse to use it anymore. There is pilocarpine available on a lollipop or a sucker or lozenge that you could have formulated. Again, same kind of thing. It works kind of short-term for patients, and I really haven't had any long-term success with anybody really wanting to use that. So, that's the way that I would approach that, Cody. That's a great question, and that's a challenge I think that we all deal with.
Good. Okay. Awesome. And the last question I have are there any benefits of brushing with a toothpaste that does not contain any type of remineralization?
Are there any benefits of toothbrushing with something that doesn't contain any remineralization? Like, okay, Cody, I got the question. And the answer to that is yes. Certainly dry brushing. I mean, not using anything is better than not brushing your teeth. So even dry brushing, just disrupting that plaque on your teeth, the biofilm, disrupting it and cleaning it off your teeth every day, even without putting anything on it, is a benefit. Now, is that as big a benefit as using something that has remineralizing agents in it, and I'm thinking nanohydroxyapatite here versus fluoride and maybe a combination of both? No, I think there's a better benefit using that, certainly. But toothbrushing by itself, we have two studies. We have two studies that indicate toothbrushing does reduce your decay rate, and they really didn't look at what people brushed with in those studies. One was just did you brush infrequently versus brushing every day, and the other one was just teaching a child how to brush it during nursery school when they're 3 to 5 years old. So I think the answer, the simple answer there, short answer is yes. Toothbrushing has a benefit no matter what you do, but certainly in my mind, toothbrushing, if you're going to do it and use something that's alkaline like your saliva, something that has remineralizing agents in it like your saliva. And again, my go-to there is NanoHA, and we reviewed in the second webinar of this series, we reviewed the 5 studies that were done in the last couple of years, just comparing remineralizing effects from NanoHA straight up against fluoride, and found that 3 of the studies indicated it was better than fluoride, and 2 of the studies, the NanoHA was at least as good as fluoride. So certainly I think there's an additional benefit of using a remineralizing product while you're using a toothpaste or while you're brushing. So yes, I think it's better than a product that doesn't have it. Great
Perfect.
question.
Well, I think awesome. Yes. So I think that's all the time we got. Thank you, Dr. Kutsch. Thank you, everyone, for joining us tonight. If any other questions, there were a few more. If we didn't get to those, we will, in the next week or so, get back to you and get an answer for you. And if there's a part of the webinar that you want to see again as well, you'll have the recording here in the next couple days. And please contact us if you're interested in implementing CariFree into your practice, or want to just schedule a quick meeting to kind of go over risk assessment and talk about some of these concepts. We're happy to help assist you in any of that. So thanks again for joining us, and have a wonderful night, everybody.
Thank you, everybody, and have a great week, and I will see you on our next webinar. Good night.